In this world, you will have trouble, trauma, crisis, and you've chosen to care. The American Association of Christian Counselors, in conjunction with Military Ministry, a division of Campus Crusade for Christ, present Care and Counsel for Trauma, an intense 30-hour certification program led by the nation's best crisis counselors. You will be learning from experts, gaining insight, knowledge, and practical skills. Over a lifetime, most people will experience severe trauma and pain and fear in the aftermath. Some even develop post-traumatic stress disorder. You'll be ready to help. May the Lord bless you as you study. Care and Counsel for Trauma.
It's very important to understand the ecosystem in which the people that we care for operate. In the case of a soldier, sailor, airman, Marine, that represents the military medical system run by the Department of Defense and the Veterans Affairs medical system for those that have departed from the service. These two medical systems define the ecosystem, and it's wise for the counselor of these folks to understand what that system exists for and what some of the complications are. Now, as we move forward into this series, we're going to learn about the specifics. What's the bridge between those two medical systems? How are soldiers processed after they come back from the battlefront for understanding of whether they have mental health issues, whether they carry the hidden wounds of war? All of these are important for the practitioner to understand. Now, the good news is that we have some wonderfully talented people that will be presenting to us today. Dr. Ken Farmer, Major General retired Ken Farmer, United States Army. Ken is currently the Executive Vice President of Tri-West, handling a large region of our country, Tri-Care support for our troops and our veterans. And in addition, his career tracks his last assignment, for instance, as Commander of Walter Reed Army Hospital and the North Atlantic region of our military medical system. He also has been involved in many other military things. He was a Desert Storm veteran. He was flight surgeon of the 101st Airborne Division. He was commander of an Army hospital at Fort Polk, Louisiana. Here we have a man with great experience and wisdom that goes far beyond the military system, but it goes certainly into the civilian community, certainly a benefit to all of us. And then complementing him is Dr. Lee Bishop. Dr. Lee Bishop is a staff psychiatrist at the Michael E. DeBakey Hospital, Veterans Affairs Hospital in Houston, Texas. Dr. Bishop was assigned by the Veterans Affairs to help us understand the Veterans Affairs medical system so that we as counselors can best team with them on behalf of troops and veterans across this country. So please welcome Dr. Ken Farmer and Dr. Lee Bishop. Thank you. We are honored today to have Dr. Ken Farmer with us to initiate our discussion of military and veterans healthcare systems. Dr. Ken Farmer, Major General retired Ken Farmer, former commander of Walter Reed and many other wonderful assignments in the military. And now he's the Executive Vice President and Chief Operating Officer of Tri-West Healthcare Alliance, which really services the Tri-Care system in a large number of our western states. So it's an honor to have you, Dr. Farmer. Ken?
Bob, it's very nice to be here.
It was a great privilege for us to bounce off one another in our military careers,
right.
And I had great respect for your compassion and your expertise with military men and women.
Well, I'm glad to reconnect and to reconnect in such a wonderful focus and ministry here.
Yeah, for sure. Well, what we want to do is give the counselors that are listening to this, the church members, the pastoral councils, an idea about the ecosystem that the military person swims in. and particularly for the wounded warrior. Maybe it's most appropriate. Let's just start off. We have a great American in Iraq or Afghanistan. He's out there doing his job, but he gets nicked. He gets nicked physically or he gets nicked mentally. That sort of starts the medical system on the triage side. So could you discuss the military medical system, and particularly in wartime?
Well, sure. And it's a very complex system, but let me sort of start first on this side. When you look across the United States, the military health system is really a combination of the direct system, military hospitals and clinics, owned and managed by the Army, Navy, and the Air Force in support of our services. And a lot of the care is in those direct hospitals and clinics. But they can't do everything for the 9 million military members and family members and retirees and their families eligible for care. So they've partnered with some companies like mine to build networks of private practitioners and facilities to augment the military health system, and that's what we call the private sector care. That has been particularly important as we have been in this war effort in Afghanistan and Iraq, because the doctors and the nurses in the military hospitals and clinics, while that's their day-to-day job, many of them, most of them, have an alternative duty assignment. When the service needs them, they will deploy with a deployable hospital or a ship or another deployable platform. And so you have many doctors and nurses and healthcare professionals who normally serve in a hospital or a clinic and somewhere in the States, but today are serving in Iraq in a combat support hospital or another deployable unit. And so this private sector care network fleshes out on this side. But now let's jump over to the Iraq and the Afghanistan. The audience watching this who may not be familiar with the military system would be amazed at the sophistication of the technology of what we've got over there. I mean,
very likely the best in the world.
We've got the best trauma center in the world is right now is sitting in Iraq supporting those great men and women. And so a person injured in IED or another injury in Iraq or Afghanistan is generally got first-line medic intervention, and those medics are very, very well trained to do life-saving interventions, and they do that every day. Then a very sophisticated evacuation system with ground vehicles and helicopters, which will get them generally within minutes to a forward surgical team where life-saving care and intervention can be done. And then deployed combat support hospitals, trauma hospitals in the theater of operations. One of the things that is different today than in previous wars is our ability to move from Iraq or Afghanistan to Landstuhl, Germany, very seriously injured servicemen and women very, very quickly. In the past, we could only move when they were stabilized, and that sometimes took weeks. Now we can move stable, but we can move stabilized but not stable patients now. So
because of the amazing technology
technology we have, the ability to have literally intensive care units in the air. So we are often moving seriously injured servicemen and women within 24 to 48 hours to a very sophisticated military medical center in Landstuhl, Germany, and then often within a day or two of that back to Walter Reed or Bethesda or Brooke Army Medical Center or another one of the medical centers in the States. So this seamless transition of care from the deployed theater to generally Landstuhl, Germany, and then back to the most appropriate medical center here in the States, chosen by service, by where the family is, by where they would get their best level of care.
And along the way, no doubt, care and compassion for the families and the loved ones who are wondering and so forth.
That's absolutely, and as a matter of fact, over the course of the last number of years, the military has put policies, procedures, authorizations in place to bring family members to be with their seriously injured loved ones, sometimes in Landstuhl, Germany, but at other times back to Bethesda or Walter Reed or Brook or wherever, and to care for that family and to give that family some support and per diem and transportation to be there for as long as it's appropriate and necessary for them to be with the loved one.
And the wonderful work of the Fisher houses as an extension, really, of the military medical system to care for that family.
Exactly, and that we have found that's very, very important to the patient. It's very important to the milieu of recovery and treatment of the patient and the family. Exactly.
Now, Guard and reservists are being deployed with unprecedented tempo, even greater in many cases than World War II.
Right.
They're in the woodwork of America. They have health care needs. They get banged up. They're the exoderm. They get cut and bruised.
Right.
How is it different for them?
Well, you know, the Guard and Reserve used to be euphemistically referred to as weekend warriors because they would go out and train a weekend a month or whatever. No longer is that moniker used because their operations tempo and both the frequency and the duration with which they're deployed has been phenomenal, as you just alluded to. And in recognition of that, the Congress and the Department of Defense has put in place a number of improvements and advantages for them, specifically targeted to the Guard and Reserve and their family members to recognize and to support. I mean, there are new programs of coverage in the military health system, TRICARE Prime Remote, TRICARE Prime Remote for family members that specifically address this TRICARE military benefit to places that aren't around military hospitals and clinics that apply to the Guard and Reserve members out in the small towns and hamlets across the country. My company and those in the other regions, we have gone to great efforts to extend our networks, which used to be largely focused around the military hospitals and clinics, but to expand those networks across to meet the needs of the Guard and Reserve.
Sure. Prescott, Arizona, just north of you, for instance.
Exactly.
They're not near a Fort Hood or a big military hospital,
but we've got a robust network, and that is in part to support the Guardsmen and Reservists and their families that are there.
Well, that's great. Now, these Guard and Reserve families, they're all in the woodwork of America. They're across the whole expanse of our nation. Do we have enough healthcare providers to really meet that need across the whole breadth of our country?
Well, that's one of those questions where do you have enough? There's always going to be the question for any one each. But as I said, we've moved over just the last few years dramatically. I mean, we have 140,000 plus providers in our Tri-West Healthcare Alliance over our 21 states. About 16,000 of those providers are in the behavioral health, mental health area. And as I said, the growth over the last few years has been particularly focused in the broad areas away from military treatment facilities. We're always looking for gaps and needs and opportunities to expand that to meet the needs of people. But when we have a need of an individual and we don't have someone who is officially a part of the network, we get them to other providers to meet that need.
Sure. It seems like there might be an opportunity for those that are viewing this video and go through the certification process to in fact become part of this TRICARE provider network as a way to access needy military families in the behavioral health arena. Is that correct?
Absolutely, and I think your audience viewing this, many of them probably are part of the American Association of Christian Counselors, and I want to assure them that pastoral counselors are one of the categories of TRICARE certifiable providers. And so in addition to psychiatrists and PhD psychologists and licensed social workers and other kinds of counselors, pastoral counselors can become a part of the network, and we would be very interested in, as a follow-on to this, providing those avenues of connection and to express that interest and do that.
Well, that's tremendous, because I know there's a lot of people out there, a lot of educated, bright, competent people that want to help. Now, the challenge sometimes is that we can bring the horse to water, but we can't make him drink. The stigma of seeking health care, particularly behavioral health care on the military side, military leaders are trying to reduce that. The Secretary of Defense has just taken some recent moves. But there's still a stigma. Would you address that?
It's absolutely, and I applaud the efforts across the nation and the Secretary of Defense's recent efforts, that of the Chairman of the Joint Chiefs of Staff and others, to destigmatize the getting seeking mental health, behavioral health care. I go back to shortly after the Gulf War Desert Shield storm. The Army specifically put into place something we called combat counseling teams to be part of the deployable force. And these were psychiatrists, psychologists, and other behavioral health professionals in small cells to be deployed into a theater, to be the eyes and ears and support of commanders, and be out there to look for opportunities of preventive behavioral health care.
Right, and assist with critical incident debriefing and things like that.
Critical, when there was a critical incident, to go in and not do counseling or do therapy, but to work with soldiers and units to prevent that from, blossoming into more serious problems. We put into place a lot of other things. Suicide prevention programs and other things to begin to work proactively and preventively with soldiers, with units. And the second order of that is to begin talking about it, and talking about it in a routine, preventive sort of way. That is really germane to your question about destigmatizing.
Right, sure.
It's not something to ignore. It's not something to shove into the closet. But I think that as a result of the war efforts, and many looked at early on, amputations were often called the signature injury of the war, and then traumatic brain injury, and more recently, some are beginning to say, maybe the real signature injury of the war are those injuries that we don't see visibly, but it's the impact, on the psyche, on the mental and behavioral aspect.
Right, and maybe just a bit more we could address the hidden wounds of war.
Right.
You're obviously familiar with the term comorbidity.
Right.
So many of these wounded warriors that have an outwardly visible wound also have inward wounds that can't be seen, and so you have to treat these together, and it's a complicated process.
Well, I more than 25 years ago, I developed a talk at an Army chapel at Fort Polk, Louisiana, built around the verse in 12th chapter of Mark, the 30th verse, where the Lord says, "And you shall love the Lord your God with all your heart, with all your soul, with all your mind, with all your strength. And my talk, which I've given on a number of locations and situations since then, was sort of built around, why did the Lord choose those 4 words? And it addresses the emotional, the spiritual, the mental, and the physical dimensions of who we as human beings are. And that we are complex creatures, and every one of us has a part of who we are in those dimensions. We aren't just physical. And if we ignore the spiritual, the emotional, we are ignoring part of who we are. And balance requires addressing all of those dimensions of our being. And nowhere is that more true than in an injured person, and a person who has been exposed to atrocities and horrors and the ravages of war. So I think that that's the context here, is whether the primary problem appears to be mental, emotional, behavioral, or whether the primary problem is something physical. All of us have a need to pay attention to what's going on inside of us. And so this effort to destigmatize that,
Right.
and to open those avenues, both for the care and to open the avenues within an individual to get and seek that care, is extremely important.
Well, that's wise counsel, I think, this holistic approach. And what we're seeing as a faith-based organization is that there's a very direct role for faith in this process. And we say that from a faith-based perspective, God is the healer.
Right.
And we're finding amazing anecdotes of troops that come back and they have these hidden wounds of war, and through spiritual renewal, they in fact begin to heal from their hidden wounds. That complements their total healing process.
Right.
Well, I know, Dr. Farmer, you have spent many times in hospitals, and particularly military medical hospitals, Walter Reed and others. Probably the counselors across our country would benefit from some of your observations about how do you deal with a wounded warrior? How do you talk to him? How do you get out of your comfort zone and just wrap an arm of compassion around him?
Well, the first response to that is you just talk to them as you would talk to any of your other friends and neighbors and contacts. They're ordinary people who have done extraordinary things when the nation needed them to do that. And they're generally very open to talking about that. And so just, asking them to talk about their experiences and, hey, how was it over there? And tell me about your mission. To an injured troop, well, tell me about your injuries. Many people are afraid to ask that, but most wounded warriors are very happy to talk about their injury, how it happened, and then just going with the flow of a conversation like you would with anybody else that you're talking to. That's the best counsel.
Well, I think that's wise counsel. And then obviously the healing process doesn't end in the hospital.
Right.
But then they go out into the community. Can you address the role of churches, the role of other community organizations?
Absolutely. Again, back to this holistic approach. I think the church and the Christian and caring community becomes a particularly important part of dealing with not only the spiritual but with the emotional needs of these folks. One of the individuals that writes a lot about treatment of post-traumatic stress disorder, Dr. Martin Glasser, out of San Diego, California, who himself served as a psychiatrist in support of the Marines in Vietnam. When he talks about the steps to treating PSD, his first step is building trust. That's written from the perspective of a psychiatrist treating a patient. But I think it applies to your question about a church community with a patient and family, building trust, building relationships, and then moving on to other steps of connection, of openness, and of caring.
Exactly, and they come out of the hospital, they go into the community, and they also then have the opportunity to enter the Veterans Affairs system. Could you just briefly address transition into the Veterans Affairs system?
Absolutely. First of all, for a wounded warrior, they may get their care depending on the needs and where they are. Wounded warrior will generally get most of their care inside the military health system in a Navy or an Air Force or an Army hospital. But they may get some of that care out in our civilian networks at appropriate specialists and facilities. Even while they're on active duty, we will get them into VA medical centers, into their polytrauma centers for some of their specialized care, particularly some of the traumatic brain injury care. So the military health system and the VA health system intersect and interact and work together, even for those wounded warriors who are still on active duty. When a service member who is discharged and released from the military, who does not have a retirement from the military, will generally then be eligible for care in the VA system and would get most of his or her care in the VA system, not in the military system. Those who retire from the military or have a medical retirement are generally eligible to get their follow-on care in the military system, but also may be getting some of that care in the VA. And so we intersect, we look for where is the best care for this particular condition.
That's great. And our goal is obviously to make a seamless transition for that wounded warrior or for the veteran. We may be talking about Vietnam veterans, that are in the VA health system now and so forth. Well, good. This has been a wonderful benefit, I think, to the counselors across America. I would afford you the opportunity, Ken, to just anything you would say to affirm first our military men and women that serve us day and night and their families, and then also anything to the counselors that would seek to help them.
I think, first of all, I applaud your organization and this effort, and which is directed largely at familiarizing a segment of society that wants to help, who hasn't necessarily been exposed a lot to the military and the military system and soldiers. So this familiarization is important. I would encourage your folks who are interested in becoming a more formal part of this care to contact folks like our company to become part of the network. But I think that building relationships and caring for people, men and women, as men and women, and families, not just patients, is extraordinarily important, and I appreciate this effort.
Well, that's wonderful, and thank you, Ken, for your service to the nation, your service to God, your service to many others, not only in the military, but now beyond the military. And so now we transition to Dr. Lee Bishop, who's going to give us the other half of this equation, helping us understand the Veterans Affairs medical system so that we get really total comprehensive health care for those that are serving our country, but also those that have served but continue to linger with the wounds of war, both physical and hidden. So thank you very much. I I previously had the honor of introducing Dr. Lee Bishop from the Michael DeBakey Veterans Affairs Hospital in Houston, Texas. I also noted that he was a lieutenant commander in the U.S. Navy. I want to expand upon that. It's good to have you with us, Lee.
Thank you, Bob.
Thank you so much. You are a lieutenant commander in the U.S. Navy, and this is a recent thing. Now, you recently enlisted.
That's true.
And you've already been on a deployment.
Mm-hmm.
That, to me, says you have the heart of a great patriot. And what was it that caused you to do this at a rather late stage in life?
Well, I guess it's a combination of factors, Bob. You work with these men and women that are coming back from the combat zone long enough, and it kind of rubs off on you. And one of the things that I had a growing sense of was that the costs of the current conflicts are being disproportionately borne by a small group of Americans, and those are our men and women in uniform. And so when a recruiting card arrived in the mail looking for psychiatrists to join the military, the idea kind of got under my skin. I've got family members who have served in the military, an uncle who was a Silver Star winner in World War II, cousin who was a Marine in Vietnam, and I guess thinking not only of them but all the men and women that have served, this was just a small way for me of saying thank you.
Mm-hmm. Well, you're a great American yourself, and we really appreciate you for your service. Is there anything else you might like to say on behalf of troops and families? Any word to them before we begin?
Well, I guess the word would be just to encourage them, to let them know that their work, their sacrifice, all that they're giving is greatly appreciated. And oftentimes they may not hear that directly from people around them, but the appreciation is there.
Mm-hmm. Well, that's great, and this is a fitting way to start, is to honor those to whom honor is due. Well, our purpose today is to chat a bit about the Department of Veterans Affairs medical system, so that counselors across America can understand how the system operates, how they might refer into that system, how they might receive referrals from that system, so that all together we can clasp arms on behalf of our troops and families that suffer in particular from combat trauma. Mm-hmm. So with that as a preface, Lee, could you give us a broad understanding of the VA medical system?
I'll try to do that. The VA medical system grew out of the mission really first articulated by Abraham Lincoln, to care for those that had borne the battle and their widows and their children. And over the years, that system has developed into the quite comprehensive and large department that we now see as an integral part of our government. The system, of course, as probably most people are familiar with, is built around medical centers around the country that serve veterans who have served in all eras of combat and in peacetime as well. The medical centers in many cases are affiliated with some of the finest medical schools in the country, and not only take advantage of those affiliations and the faculty that are associated with those schools, but also I think have been over the years developing approaches that are on the cutting edge of medical care. Just a brief example would be the VA's electronic medical record system, which is probably the best in the world right now.
Mm-hmm. Great, great. So A soldier goes through the Department of Defense medical system, which we have discussed in another part of this video, and then he comes into the Veterans Affairs system. What's some of the first encounters he has with Veterans Affairs? What does that look like for the new veteran? And in your case, I know that you work with OIF and OEF, Iraq and Afghanistan veterans.
Yes. Well, it may vary depending on the urgency of the individual veteran's needs. The process is first to enroll in the system, which can be done simply by either visiting a local VA hospital. The process is relatively simple. But I think that one thing it's important to convey as we educate counselors is that for those veterans who are not enrolled in the system, particularly if they're veterans returning from the current era of combat, if they're in an urgent situation, urgently feeling the need for care, they shouldn't let the fact that they're not already enrolled in the system keep them from making contact. In an urgent need, it may be as simple a matter initially as presenting to an emergency room in a VA hospital, or in the case of mental health needs, presenting to what's called the mental health triage clinic. We are in the VA system very proactively trying to reach out to veterans from the OEF, OIF operations at this point. And in fact, in just the last few months, we completed a project that involved proactively trying to make phone contact with every one of the veterans that has returned from Iraq and Afghanistan. So I mention that by way of illustrating how important it is to us in the VA system to get these men and women into the system and to try to smooth the way as much as possible. And so if they come in an urgent situation, our staff will take care of getting them enrolled and getting them into the system.
Mm-hmm. Great. And so you have the veterans hospitals, and then there's also something called vet centers.
That's correct. A number of years ago, largely as a result of recognizing the need of Vietnam veterans to have counseling, psychotherapy for post-traumatic stress disorder, the system of veterans centers, vet centers, we call them, was established. And so in addition to the main hospitals, in most of our larger communities, there will be one or more vet centers that are facilities that are exclusively dedicated to counseling and psychotherapy for the returning veteran, and also to the degree that problems have come up in the family related to the veteran's psychological symptoms, mental health symptoms, then they can also provide support and therapy for family members as well.
For sure. Now, your role in the Houston Veterans Hospital is to deal with OIF and OEF patients, particularly post-traumatic stress disorder.
Yes.
Could you address the hats you wear in the VA hospital, and then just generically who you see as patients?
Okay. That's a correct description. About a year ago, I assumed a position where I'm exclusively working with returning OEF and OIF veterans. We have a team that works with these veterans, made up of myself, one other psychiatrist, 3 psychologists, and a social worker. Basically, our process is once we identify the veteran, and we set up a schedule of interviews, of clinical contacts with them. The initial contact is with one of our psychologists or with our social worker initially, and they undertake to do what we call the returning veterans mental health screen. It's a lengthy interview, goes through not only the particular symptoms that they may be having at that time, but a fairly extensive background history, some family history, some medical history. Once that's completed by the psychologist or social worker, then the veteran has a scheduled appointment with me as one of the psychiatrists on the team. With the advantage of that background history already accumulated, then I can focus in on the particular symptoms that the individual is experiencing at that point, review and confirm those symptoms with the veteran. And then that gives me an opportunity to talk with them about any diagnosis that has been made at that point, to talk with them about treatment options that may be appropriate, and particularly since I'm the psychiatrist, the MD on the team, I can focus in and talk about the biological and neurological aspects of PTSD and post-combat depression, medication, and physical forms of treatment.
So that's really the first exposure to you, and those are the things you investigate.
Yes.
With this person.
Yes.
Now, I know that there's a gentleman named Robert Nuttall and wife Amy who had a particularly complicated experience coming out of the military. He had PTSD, but then a very serious traffic accident which left him with traumatic brain injury as well. And I know he's given permission for you to chat a bit about his situation. Any observations or lessons learned that might be more broadly applied?
Well, I think that certainly Robert's situation in many ways, even though his brain injury occurred after he'd come out of the combat zone, it illustrates one of the most common combinations of problems that we see in the current era of veterans. It's often said that the two signature injuries of the current era of combat are post-traumatic stress disorder and traumatic brain injury. And Robert has had both of those. I think that he has done a wonderful job in making use of a variety of treatment sources around him, and in adapting with these conditions, making some very difficult decisions about changing career plans that were necessitated by these injuries. Robert has drawn very deeply on his own deep Christian faith, and I think that that's been a tremendous support for him, and I think that his ability to do that has really made a difference in his recovery.
Do you find, Lee, that faith is a very relevant factor as a complement to other approaches related to PTSD in particular?
I do, Bob. I am aware, as are many therapists, psychiatrists, that in the setting of post-traumatic stress disorder, particularly in the situation for combat veterans, very often there is what we might call an existential crisis that's associated with having gone through the trauma. Veterans come back with questions like, how could God let this happen? Or how could God let this go on without intervening? In many cases, they may have gone into the combat situation with at a stage in life when they still have some questions, and their own faith life is in a formative stage. And for those who are able to address those questions and to find a grounding in faith, my experience has been that most often they're able to make a more rapid transition toward recovery or their PTSD. There remains to be done definitive scientific work on many areas of that, but we do have good studies in other areas of mental health conditions suggesting that faith very often is a strong factor in recovery.
I was going to ask about that. The term resilience is often, in some scientific studies, I know that resilience is enhanced from a faith perspective, and in a more pragmatic sense, ounce of prevention worth a pound of cure. I'm just wondering, do you think if a man or woman looks at life through a faith lens en route to their traumatic experience, that they are more resilient at the other end?
My personal opinion is that yes, that's likely to be true.
Yeah. Well, as you deal with many situations in the Veterans Affairs, I know that you do not have the single solution, but you have to partner with many others. And part of that partnering is the local community. Could you discuss the benefits of outreach to the local community, churches, civic organizations, other things like that?
Sure. I think that one of the things that we see in a lot of our returning veterans, because of the effects of PTSD, and because of the transition they're experiencing from a close-knit group of buddies, fellow Marines, sailors, soldiers, to back into civilian life, is that in many cases it's a little bit difficult, maybe very difficult in some cases, to reconnect with people around them. And I think that one of the things that we certainly want to encourage them to do is to find ways that they can do that where they can be supported by a mature, loving community of people. Faith-based groups, churches, particularly if they have taken some time to learn about the needs of veterans coming back, can provide a very natural environment for that reconnection to take place.
That's great. Have you seen any examples of this in Houston?
Well, I think speaking back of Robert, certainly he's a case in point. A somewhat unusual case because Robert himself has now moved forward to actually enter seminary training. But I've seen a number of others in my practice, individuals who have connected with the church, a group of one kind or another that supports them. And I'd say in most of those cases, that's been a very important factor in their recovery.
Recently, Secretary of Veterans Affairs Jim Peake remarked to me that oftentimes these troops coming home, understandably, are not real serious about their post-deployment health risk assessment. You know, they just want to check the block, get off to see mama or whatever, and get on with life. And really the first time that they seriously consider their situation, and the first wake-up call perhaps is in a church or a community organization or within the body of the family. And so it seems very important for us to help orient these type of groups to partner with you in many ways.
I think that's true.
Yeah. Now I'm thinking what we've described as sort of an outpatient system where a veteran might go to a vet center or they might go to the Veterans Affairs Hospital. Is there also an inpatient process? What if somebody's very serious? For instance, I've heard of the Martinburg, West Virginia facility. Could you discuss inpatient matters?
Well, most of our VA medical centers are going to have inpatient facilities available for treatment of PTSD, depression, and the variety of difficulties that our veterans bring home with them in many cases. I think one of the things I like to address with my veterans is that if there is a need for inpatient care, that oftentimes that involves a fairly short stay in the hospital. I think there are a lot of myths around inpatient psychiatric care that keep some veterans from considering that as an option. But in many cases, particularly in a situation where there's a crisis where an individual may be experiencing suicidal thoughts, getting them into the hospital helps to move the treatment along more rapidly. It allows us to do a number of things that would take a longer period of time to do on an outpatient basis. It also allows the veteran to kind of step back from the pressures that often face them when they've come home from deployment and be in an environment where they're not being pushed quite so much to deal with so many problems. Kind of a timeout, if you would.
Good. Now, many counselors across our country are dealing with Vietnam veterans, and some are dealing with the younger veterans coming back from OIF, OEF. Is there any way you would distinguish or words of wisdom about dealing with these different populations? Is it useful to deal with them together, deal with them separately? Any thoughts about that, Lee?
Well, I've seen it work both ways. In some cases, I have seen where there are enough differences that dealing with them together has been a challenge. In other cases, I have seen situations where the younger veterans find the experiences of the Vietnam veterans and the knowledge that they've been through it before and they've survived and in many cases flourished, where that can be very encouraging. I do see some differences between them, and the most obvious and logical one is that they are dealing with different generational issues. The Vietnam veterans, by and large in their 50s and 60s, are dealing with life stage issues that are particular to that age group. That's a little different from the 20-year-olds and 30-year-olds that are coming out of the current era of combat, who are just starting families, who are starting careers. They have different kinds of issues that they're dealing with. I do think the historical context is pretty important too. The Vietnam generation came back from the war at a time when the United States was in a great deal of turmoil about the purpose of that war. And in some cases, the Vietnam veterans found that what was traumatic for them, even more than being in the combat zone, or what they felt was more traumatic, was coming back and facing a very ambivalent public that tended to identify them and over-identify them with their doubts about that war. I think, at least to some degree, America learned from that experience, and to a much greater extent is trying to support the troops as they're returning now. And I think that shows. I think that our current troops coming back are not having quite the stress that perhaps the Vietnam veterans had in finding that ambivalence and in some cases really a negative kind of view of them when they come back.
Well, these are great words of wisdom for counselors all across America. Is there anything else, Lee, you might that might come to mind to mention for those who are interacting in a counseling sense with these returning veterans?
Well, I think one thing that studies have borne out is that makes this generation of veterans very much like those that came before, and that is that they're very uncertain and wary about seeking health, mental health evaluation and treatment. They're concerned about the stigma that's attached. Studies that have recently been done have really confirmed that some of the biggest barriers to seeking mental health treatment are the fear that it will be a sign of weakness, the fear that it will have an effect on their military or even civilian careers, and the fear that others around them, maybe particularly their buddies or shipmates, will see it as a sign of weakness. And so I think overcoming that is very important. In my first encounter with the veteran, I first of all try to make it clear to them that this is not a character problem. It's not about being weak. Some of the bravest men and women that I've ever met suffer from PTSD, and they suffer from it indirectly because they are so brave. They were willing to put themselves in situations where their life was constantly in danger, and they were under some of the worst battlefield stress. And so the fact of having PTSD or post-combat depression doesn't signify that there's a weakness or a problem in character. It's an illness, and we need to see it that way, to treat it that way, and to try to help the individual move beyond that stigma.
Lee, I know that you're familiar with the Combat Trauma Healing Manual. This manual is a new tool. It does provide Christ-centered solutions for combat trauma. We've talked about the importance of faith in many people's lives. Do you have any comments regarding Combat Trauma Healing Manual and how it might help others?
Well, I have reviewed the manual. I think that it's a well-written and encouraging summary of not only the problems that can be faced by our returning combat veterans, but some of the ways that faith can be integrated into a whole package of recovery from that. For those veterans that I see who are wanting to integrate their faith life into the healing process, I will sometimes suggest that they take a look at the Combat Trauma Healing Manual and look at some of the resources in there to see how they might use that.
The VA for me has been fantastic. I started out in a VA hospital in Waco, meeting with a psychologist, and he met me and fit me into his schedule when he didn't even have time because I was a new patient and he had been booked out significantly, and he made time for me as much as I needed to meet with him. They offered me medication, they offered inpatient treatment, and they offered a small group setting at a different VA hospital. I didn't want to try the medication at first. I never did. I didn't want to do the inpatient treatment because I needed to be with my family, working through this as well. But eventually, when I moved towns to a new VA hospital, they had a small group of veterans from Iraq, Afghanistan, and the first Gulf War who were meeting to talk about their symptoms. And that was beneficial for me, although it was provocative for me, and it brought out a lot of volatility in me because it made me deal with symptoms, and it was at times depressing to look around the room and see how all these other guys were dealing with their own problems that had come from combat stress. It also helped me understand that this was a normal reaction to abnormal events, that although we call it a disorder, it's actually a normal. I mean, if you don't have these kind of reactions, then you have to ask the same amount of questions of why am I not affected by these things? Because we weren't created to do these things. It's just a result of sin in this world. And so the VA gave me a lot of education about what PTSD was, what the symptoms were. I still had individual treatment. It was really good for me to understand from a mental perspective what I was going through and how to recognize signs and how to defeat some of the symptoms, or at least cope with some of the symptoms. But for me as a Christian, there were still some things missing. And a month or two after I started going to the PTSD group at the VA, we started a PTSD small group at our church, which gave me the spiritual aspect of exploring these traumas and how to make sense of them through Scripture and through relating to people in the Bible and praying through it and talking through it with other people from a Christian perspective.